Hey guys, nice to see you again. Let's enjoy Dr. Y's Chest Radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today, chapter 33, pulmonary nodule, lung nodule, second edition, chest x-ray and CAT scan findings, part 1 of the 2. Let's go. I make this second edition revision about lung nodule video since there has been update of lung nodule definitions by Fractional Society year 2024. This chapter is about introduction and review of the nodules. The images of the nodules will be on next time. Let's begin. Two main references of this video, these chapters are 1. Alexander Benke et al. Fractional Society Glossary of Terms for Thoracic Imaging Radiology 2024. 2. Konstantinos et al. Lung Nodules, a Comprehensive Review on Current Approach and Management, Anal Thoracic Medicine 2019. I hope you all get familiar with radiologic terms of nodules. Nodule is, by definition, Fractional Society 2024, as we all know, a circumscribed, typically round opacity, less than 30 mm in average diameter, less than 3 cm. We may usually call the nodule as solitary pulmonary nodule or single pulmonary nodule, sometimes SPN. Sometimes we may say coin lesion, and usually we say lung nodule. As we know, there are many names about the nodules and nodules friends. First, miliary nodules, less than 3 mm, numerous, even in size. Micronodules, this is important because it's been changed from less than 3 mm to less than 6 mm. And ditzer, it is not a medical term, usually means small, 3 to 5 mm, small nodule, and nodule, less than 30 mm. Ground glass nodule, GGN, not obscuring pulmonary vessels. Subsolid nodules include pure ground glass nodule and part solid nodule. Mass is bigger than 3 cm. Lung nodules are common, very common. They are from various origins, from various diseases. Most of the nodules are benign from infectious origins. Nodules usually make us nervous, especially makes the patients nervous. Nodules sometimes become lung cancers. What's up with nodule? The incidental finding of solitary pulmonary nodule in asymptomatic people is a common clinical dilemma encountered in daily clinical practice. Is nodule same as lung cancer? No, definitely not. They meet in small portion, just like this yellow egg, yellow football. According to Glossary Fractional Society 2024, a rounded lesion bigger than 30 mm is mass. Less than 6 mm should be called micronodule, a term which serves to distinguish it from larger, potentially actionable nodules with or without current management guidelines. Terminology described below is intended to standardize the description and reporting of nodules, while acknowledging that nodules represent a morphologic spectrum encompassing both benign and malignant features. Shape and margin of the nodules. Shape is described as round, ovoid, or polygonal. Configuration is spherical, flat or elongated based on their appearance in various imaging planes. Margin is described as well-defined or ill-defined depending on the appearance of interface with the surrounding lung. A smooth nodule border is even and free of substantial protrusion or indentation, as opposed to an irregular border. Shape and margin. Irregular borders can be, this is important, irregular borders can be 1. Lobulated with lobule-like protrusion, we call it lobulation, and or 2. Spiculated with multiple radiating small sharp projections, needles, we call it spiculation. These two terms are important, lobulation and spiculation, because they might be lung cancers. And pleural tags, linear components extending from the nodule to pleural surface. Combinations of the above shapes and margins may occur. Ladies and gentlemen, you quit smoking? Wonderful. Peace be with you and peace be with your children. Attenuation and structure of the nodules. Ground glass nodules based on attenuation. Nodules with pure ground glass nodules are ground glass nodule. Solid nodules, pure soft tissue attenuation nodules. Part solid nodules, PSN, nodules with both ground glass and soft tissue attenuation components. In the context of adenocarcinoma, the ground glass components generally correspond to lipidic growth and solid components to invasive growth patterns. Attenuation and structure of the nodules. Thin section CT is essential, not thick section CT, for accurate characterization of small nodules. Simple nodules show a single structural components such as soft tissue, ground glass, calcification, fat density. Complex nodules have more than 2 structural components. Simple nodules can develop into complex nodules and vice versa. Location of the nodules. Nodules are peribronchovascular or centrilobular, depending on their location in relation to other structures. Fissural nodules arising from a fissure. Perifissural nodules, direct contact to a fissure but not arising from it. Pleural nodules arising from the pleura. Location of the nodules. Pleural-based nodules, direct contact to pleura, not arising from the pleura. Subpleural should only be used for nodules in proximity to pleura, but without direct contact to it. Because this term has been attributed variable meanings in literature, the term peripheral is preferred. Differential diagnosis of solitary pulmonary nodule. Differential diagnosis of a solitary pulmonary nodule is broad, very broad. Occurrence of relevant symptom is important. Numbers of the nodules also important. Imaging characteristics, location, shape, presence, and type of calcification, presence of spiculation, cavitation may narrow the differential diagnosis or even point toward a specific entity. Guidelines according to nodule size, strongly associated with probability of malignancy. This is important, telling us about the odds of lung cancer possibility and what do we do about the follow-up of the patients according to the size of the nodule. First, less than 6 mm, acceptably low cancer risk, less than 1%, so we do not need routine follow-up for the nodule less than 6 millimeter. And second, nodule less than 8 millimeter, intermediate probability of 1% of lung cancer. So we do follow them 6 to 12 months. And if the nodules are bigger than 8 millimeter, high cancer probability of 9.7%, almost 10%. So we need 3 months follow-up or PET-CT or even tissue sampling is needed. Predictors of benign etiology. First, peripheral nodule is usually considered benign, most probably depicting intrapulmonary lymph node, except speculation and fissure displacement. Speculation and fissure displacement is bad sign. Calcified nodules are generally not considered malignant, but 10% of lung cancer have calcifications. Patterns of calcification, diffuse, central, laminated, and popcorn patterns are predictors of benignancy. Predictors of benign etiology. Number 2. Punctuate, eccentric, amorphous calcifications are indeterminate patterns and should not be a preclusive of lung cancer. Fat attenuation is almost diagnostic of hematoma and excludes lung cancer as a potential cause. Who are you? What the hell are you, Mr. Nodule? Next session will be with nodule images. Like, subscribe. Thank you for watching. Please visit more. See you soon.